I have a disclaimer for this. I'm not an expert in intestinal parasites, but the clinical editor who wrote this pathway happens to be away, and I suppose I work in refugee health, so I see a few worms and I enjoy diagnosing worms when they come. So here we go. Look, I'll start with take-home messages again. Consider parasites, especially for migrant and refugees from endemic areas. Use the health pathways. For now, actually, there's quite a lot about parasites on the refugee health pathways and on infectious gastroenteritis. Going forward, this new pathway in process, it's called intestinal parasites, and it's going to be great. In terms of where you find things, look, refugee health pathways, we do focus a little bit on what we screen on. So there'll be a section called strongyloides, one called schistosomiasis, and then one called intestinal parasites, which is not strongyloides or schistosomiasis. So you need to click on that to find all these other worms. And it'll go into very briefly, really, a bit about the worms and also how you treat them. There's also a list there of non-pathogenic parasites that don't require treatment. Really useful to know if you do a few stools, because you may get things that you're like, well, what do I do about this? And this just tells you don't do anything. We don't cover Cryptosporidium routinely in refugee pathways. So if you're looking for that particular parasite, you do need to go to the infectious gastroenteritis health pathway. But the new pathway will cover everything in lots of detail, so it looks pretty fabulous. It's also going to add delusional infestation, so watch your space. Okay, so I guess for the next little bit, I'll talk about worms, my favourite worms, I suppose. And if there's one worm that I guess you might want to take away with you and to think about would be strongyloides. And the reason for this is that strongyloides is the reason why we're getting an intestinal parasites health pathway. And that's because as of earlier this year, the special authority for treating strongyloides with ivermectin has now been brought into any relevant practitioner. So it used to be ID only. So that's good. So now we can assess for it and we can also treat for it in the community. Strongyloides is a really interesting parasite. And so we get it through the skin, so it penetrates through a bit of the skin, and then it goes through. And in terms of roundworms, it's interesting because this particular parasite has an auto-infection cycle. So unlike other parasites, this one, without treatment, can endlessly just go on and on through the auto-infection cycle. Why is it important and why do we care? Look, you're at risk if you've lived for a long period in the Pacific Islands, in Northern Australia, as well as Southeast Asia, Sub-Saharan Africa and Latin America. The risk is lifelong, even if you've migrated decades earlier because of that auto-infection cycle. But the truth of it is that mostly we're asymptomatic, and so it doesn't really bother most of us. But for the ones who do get symptoms, usually in the acute phase, the worms come through usually the foot, and you might get a bit of edema, a bit of urticaria, and some non-specific symptoms. But in the chronic phase, it's more sort of abdo symptoms, pain, nausea and vomiting, diarrhea, itching bottom. But we're worried about it because there's a risk of disseminated disease, so severe strongyloides, and it can cause some very nasty things, as you can see. So ileus sepsis, meningitis, pneumonia, and it's associated with a high mortality rate. But the risk factors for disseminated disease are quite specific. Mostly think about immunocompromise, so that's your biggest risk. Also, if you're on systemic steroids, alcohol-dependent, malnourished, which all is a bit immunocompromised. In terms of who we test and how, we do not test everybody who's lived in the Pacific or Northern Australia, but we do screen for refugees, and we screen for at-risk people prior to planned immunosuppression. So if you're planning to immunosuppress somebody, it's worth checking. So you do a full blood count looking for eosinophils, and also you do strongyloides serology. There are a group of people where you'll need to do some additional testing, where you need 3 stool samples on 3 different days, and you need to write ovicysts and parasites on it to ensure that the right things are tested. And this is for the group with risk factors for disseminated disease or if they're symptomatic. And look, if you suspect disseminated disease, they go to hospital. We don't manage those. But if they are well, you need to think about contraindications to ivermectin. And the main one to consider is whether or not they've been in the country. Lower is endemic. Lower is a filaria, which, if it's treated with ivermectin, can cause an encephalitis. So it's really important to consider this on the health pathway. They'll link off to a list of all the countries where this is. Usually Central Africa, so countries like the DRC, like Ethiopia. And so look, there aren't any contraindications, then you can go ahead and treat. And any questions, IDEA's still happy to take calls. Schistosomiasis, just because I test for this a lot, I've got one slide on it. And so look, the risk factor is swimming or bathing in infected freshwater. It's in all parts of Africa, but can also be in some areas of South America, the Middle East and Asia. Symptoms are pretty non-specific acutely. Our concern is around chronic risk, and so chronic infections can cause damage to intestines, can cause damage to bladder and kidneys. Really, the eggs can get into the brain and the spinal cord, and that can cause seizure or paralysis, but that's pretty rare. So testing-wise, you test for schistosomiasis. Serology, if they're symptomatic, you can go stools. You need to write that you're looking for over-system parasites. For urine, if they've got symptoms, particularly if they've got hematuria, you need to ask for 20 mils of blood, so 20 mils of urine, so not your usual MSU, but 20 mils, so that they can look for over. Treatment is with praziquantel. Praziquantel is a really nasty thing to give people. It gives you really bad tummy symptoms, at least nausea, but a lot of tummy pain as well. Normally we pre-warn people, tell them to take with food, and it is usually just the one dose, so that's helpful. Pinworms, because I thought I'd talk about something we do see in New Zealand. This is just the one slide too. So it's visible to the naked eye. So you'll see the little threads there in the bottom. It causes itching, worse at night. You don't need lab confirmation. If there's a history, just treat it. You can do the sticky tape test if you want. And the treatment is mebendazole. You treat the whole household, and then you can repeat treatment in a couple of weeks' time just to clear it. Prevention, wash hands with soap and water. Alcohol is not that great. Use soap and water. Wash your linen, your clothes in water in hotter than 40 degrees. Okay, now the next two worms are pretty rare. We have seen them in refugee health, but you may not see them, but they're pretty interesting. So I thought I'd have a chat about them quickly before I ran out of time. This is tapeworm. It can come in the form of Taenia solium or Taenia saginata. Taenia solium is one that comes from eating undercooked pork meat, and saginata is from undercooked beef. And that's where, if it's undercooked, there may be some eggs in there and you swallow the eggs. What's interesting here about tapeworms is that maybe if you go down to the bottom bit where you see the shape of the worm, tapeworms are these great big long worms, but they have these little segments, and these segments can just come off, and they can come off and just release eggs, or they can come off and come out whole through the bottom. They're called proglottids. Now, for the tapeworm from pork, this is the one that causes cysticercosis. So the one from beef does not. And what happens with these eggs is they hatch in the stomach, they penetrate through the intestinal wall, and they move to other parts of your body. So often the muscle, quite commonly, but it can also be the brain and the spinal cord, and so you get these little cysts, all right? And I guess with proglottids, I kind of wish I'd taken pictures of proglottids. I couldn't find a good one on the internet. And so look, when you get them fresh, they look a little bit like little tadpole eggs, frog spawn, but they're about 2 centimetres, they're all jiggly and moving, and the first time I saw one I thought it was a worm, but it wasn't, it was just part of a very, very, very long worm. So if you see proglottids, send them off to the lab, they'll be able to assess what type of worm it is. If you're worried about symptoms, and symptoms can be in people who've come from Asia, Latin America, Eastern Europe, Russia, or Eastern Africa, usually tummy symptoms, weight loss, abdo pain, GI disturbance, you can send off stool samples. So 3 stool samples, over-system parasites, travel history. It's really important to know what the tapeworm is to guide treatment. And the reason for this really is that if you treat cysticercosis, you can actually precipitate life-threatening cerebral edema. And so if it is Taenia solium, just refer to ID. ID would like you to ask a few questions and consider a few things. So one is ask about a history of seizures, check them to see if they have any soft tissue cysts, and evaluate household contacts, and then give them a call. For the one from beef, again, you can treat with praziquantel. Again, nasty, nasty medication, but very effective. Lastly, I'll talk about Ascaris lumbricoides, or giant roundworms, and this is a fun one because this is the one that you might diagnose from someone who coughs a worm up on you. And so how it works is that you'll again swallow the eggs will come from contaminated soil, they go down into the intestine, the larvae hatch, they then come up to the lungs and migrate there, then you cough them up, you swallow them, and then they go back into the stomach, and that's where they mature. And funny enough, you would think that this would be quite a nasty thing, but most people are asymptomatic. The only reason normally you diagnose it is if they have a really high worm burden, which can cause a bit of tummy pain, or they start seeing worms in their bottom, or they start coughing up the worms. And so look, in tropical and subtropical areas, that is where it is. Look, testing is easy. Send off the worm or stool samples, again looking for ovocysts and parasites. Treatment's also really easy. It's your barn-dorm albendazole. If they're smaller than 1, you can get albendazole as well, but you need special authority for that. So it's fairly simple. And so that comes to the end of both my talks, and I think I've done time. So questions?